Hello, thanks for joining us. We'll let some folks funnel into the Zoom room, and then we'll get started. And Alice Cepeda says hi. Okay.
Great to see you here, Alice. Thanks for coming.
Yeah. All right, well, we'll get started. Thank you all so much for joining us. This is the University of Southern California Institute for Addiction Science Distinguished Speaker Series. And we have a very exciting speaker today in Dr. Richardson, and a wonderful colleague of hers from USC will introduce her and moderate the webinar. But first, I want just to take the opportunity to tell you a little bit about our institute, if you don't know about it. We are a multi-school transdisciplinary unit here at USC, and our goal is to bring folks together from different disciplines so we can conduct high-impact research, education, and community engagement programs that really moves the needle in the addiction crisis. I want to thank our sponsors, which is the School of Social Work, the School of Medicine, and also the School of Pharmacy here at USC, along with the Department of Population and Public Health Sciences, the Norris Cancer Institute, and probably others that I'm forgetting. So we should be in for a very exciting talk. And with that, I will throw it over to Dr. Ricky Blusenthal.
Good afternoon, everyone. I'm really excited to introduce our speaker. If you don't know, Canada and Vancouver in particular has been leading the way in novel interventions and approaches to substance use disorder there for many years, really the last 25 years, if we're being honest. And so hearing from Dr. Richardson is going to be a great treat. She's the Associate Professor of Sociology at the University of British Columbia, a research scientist in the British Columbia Center on Substance Use in Vancouver, and she holds the Canada Research Chair in Social Inclusion and Health Equity. Drawing on public policy experience at multiple levels of government, her research examines the causes and health consequences of poverty among people who use drugs. She focuses specifically on modifiable, policy-relevant aspects of upstream determinants of health and well-being, with a view to support socioeconomic and health justice for marginalized populations. I endorse your goals. Her research has been published in journals such as the Lancet Public Health, Addiction, Social Science Medicine, and Bulletin of the World Health Organization. And her work has been featured in outlets such as New York Times, Canada's Globe and Mail, the Canadian Broadcasting Corporation, and The Conversation. Looking forward to your talk, Dr. Richardson, and thanks for visiting us here in LA for the next 6 months. So if you want to see her, she's available for consultations and collaborations. Without further ado, Dr. Richardson.
Thank you so much, Ricky, for the kind introduction. I'm going to share my screen so that we can dive right in. Thank you very much for the opportunity to share some of my work. Before I get going, I want to acknowledge that the land on which I live and work and on which the research that I'm going to talk about was conducted is the stolen and unceded ancestral territories of the Coast Salish peoples, including the Musqueam, the Squamish, and the Tsleil-Waututh. And that here in Los Angeles, I want to acknowledge the Tongva, the Kits, and the Chumash, and I'm sure I have not pronounced those correctly, nations who are the original stewards of these lands, and invite everyone to reflect on their relationship with ongoing processes of reconciliation with First Peoples. Also, before I get going, I want to state that I have no conflicts to declare. But where I would really like to start is here. This is a picture of a memorial that happened in November of 2017, and each one of those stakes represents a life lost to the overdose crisis. And what I can say is that at that point in time, we were absolutely despondent that we would have seen that level of loss and that amount of loss. And we really at that point didn't have a clue where it was that we were heading. We thought it couldn't possibly get worse. But of course, where we were heading is where we are now, which is the worst moment in our collective history in terms of drug overdose mortality and morbidity. And of course, these are figures that almost everyone here will be familiar with, but the top graph shows that the US passed the unfortunate benchmark of losing 100,000 people in a single 12-month period. That was recently announced in early January. And that the distribution of whether or not things are getting better or worse across the country really is not, it's not an optimistic picture right now. I share this, I mean, we could spend an entire hour on just looking at the epidemiology of the overdose crisis, but I just wanted to provide a bit of context at the outset. In Canada, where I'm from, we are also in the height of our overdose crisis. It's worse than it has ever been. These are the 2020 figures, and the 2021 figures are showing it's worsening over time, same as in the US. But you know, when we think about distributions of overdose and when we're thinking about these different, the places that are most affected and whose contexts are producing the highest levels of overdose, you know, one of the things that I wanted to draw your attention to on the California map is the scale, where that dark red that we see in San Francisco is a rate of above 40 people per 100,000 residents in a year being lost to overdose. In Vancouver and in British Columbia, this is what our map looks like. And our scale, the top of our scale is 50 people per 100,000. And what you can see is that we have a province-wide crisis. And one of the things that's happened in the last year is they had to change the scale when they put out these maps. Otherwise, it was just an entire wall of dark brown. So they actually had to change the scale so that it was it could capture a greater range. And I share all of this in part just to set the context and in part to point out that, of course, if you look at recent numbers, and this is what the Public Health Agency of Canada has provided in their most recent update, if you look at the numbers, things got really, really bad starting in the beginning of the pandemic. And so what we know is that the pandemic is exacerbating the problem. If we take a bit of a longer view, these are the numbers from British Columbia that go back to the mid-90s. What we can see is a very abrupt and dramatic increase in overdose death. And it is the kind of thing, if you look at a similar figure for the United States, it's a much more gradual increase. Our dramatic increase really coincides with the introduction of fentanyl and synthetic opioids into the drug supply. And so when we're talking about the overdose crisis, we're also going to have to talk about responses. And I'm going to mention a few things briefly, just because, as Dr. Blumenthal mentioned, in Canada and British Columbia and Vancouver in particular, we have been very fortunate to have a very large group, a very sizable research infrastructure, and we also have really strong community groups, and there is some political will to take risks to do innovative things that haven't really been done necessarily in other places. And so for us, supervised consumption sites that you'll see in the picture in the middle are something that we've had for almost 20 years and that have proliferated under the most recent federal government. Things like take-home naloxone, drug testing facilities, those kinds of things are very common in our context. And we've really benefited from that. And there's an evidence base that supports all of those interventions. And more recently, we have had the opportunity to experiment with some advanced models that are looking at trying to address that toxicity in the drug supply that I mentioned earlier. And that those models so far have been really medicalized models, but we have at the BC Centre on Substance Use developed guidelines, for example, for injectable opioid agonist treatments and the prescription of opioids to really try and separate people from that toxic drug market. But there's also been this broad recognition that things like a broader safe supply of drugs and decriminalization are really going to be critical to stemming the overdose crisis. And One of the things that I can offer is that, at the beginning of the pandemic, it was recognized that there were potentially severe consequences for overdose. And those risk mitigation guidelines that I have a picture of there are a medical model of safe supply where physicians have been authorized to prescribe a range of pharmaceutical grade drugs to try and substitute people's street drugs and avoid that toxicity. That medical model has also been accompanied by a more community-based model that has yet to be implemented, but there is a lot of momentum around developing what will essentially, we hope, function like a heroin compassion club that is much more a community-based model of getting access to a safe supply of drugs. And while these are really promising developments, there's been evaluations and a lot of commentary that the rollout has not reflected the vision for these interventions. Doctors haven't really been willing to prescribe according to the risk mitigation guidelines. There's a lot of difficulty in even accessing medical care these days. There have been models put forward, for example, by Mark Tyndall to put Dilaudid in vending machines to try and take that model out of the doctor's office. But of course, then you have issues of coverage, of diversion, of potential vandalism as well. And so I say, we are trying to do innovative things, and the rollout is often not reflective of the vision. That doesn't mean we shouldn't do them, but it does mean that it is a work in progress. And on decriminalization, there's also a lot of movement right now, and it's really an interesting time in that both the city of Vancouver and the province of British Columbia have produced submissions to our National Ministry of Health asking for permission to decriminalize small amounts of illicit drugs and really try to reduce the levels of criminalization that we know produce higher risk substance use. And again, here I can attest, and I'm not going to go into a ton of detail, but I'm happy to connect with people if they're curious about this in further detail. Unfortunately, in attempts to make the thresholds that people would be allowed to carry on their person in a decriminalized way, in an attempt to make those evidence-based, myself and a number of colleagues provided data to the city and to the province and made recommendations that we thought really reflected an approach to decriminalization that would be effective, particularly for some of our most vulnerable folks who are using. But that evidence base was essentially ignored. And so what we are seeing is that the decriminalization, while again, really ambitious and laudable in vision, in implementation is really proving to be really tricky. It's a really tricky thing. And so of course, we'll be watching Oregon very closely in the next little while, but these are all in process. And I can say that it hasn't been as smooth as we might have hoped. One of the things that I really want to emphasize is that, and something that I'm going to argue today, is that most of these interventions, with the exception of decriminalization, but again, could be argued, most of these interventions are really focused on the act of using drugs. They're focused on syringe services or supervised consumption or naloxone, right? Really trying to intervene in the act of drug administration. And that's really important. I'm not here to say that those interventions are not important, but what I would argue is that we have decades of research that tell us that context matters, that environment matters, that policy matters. And we have a mountain of observational research that tells us that context and policy and these broader environments are important. But what hasn't really moved upstream to think about context and to think about policy is our intervention response. And so there's a bit of a gap in what we've done as people who do research on drugs. You know, these frameworks are decades old, but our intervention work hasn't really moved to that sort of contextual modification, or how can we modify context beyond contexts of direct drug administration around supervised consumption. And so what I hope to talk to you about today, and what I'm going to argue, is that we have some work to do, and that work is both possible and important. even if it doesn't always give us the answers that we're looking for. And so I'm going to start I'm going to offer a case study, and that case study is really going to stem from work that is close to my heart, which is the relationship between poverty and socioeconomic well-being and drug poisoning or drug overdose. And to get a handle on the literature in this area, with my team the last few years, I've conducted a couple of systematic reviews that really tries to get a handle on the observational work that's been done and whether or not there's any intervention work. And so this review came out in Drug and Alcohol Dependence in 2020, which coming up on 2 years ago now. It's hard to believe in the current time warp. But what I can tell you from this particular systematic review was that the evidence base is really limited. Most analyses were primarily interested in independent variables that had nothing to do with socioeconomic status or well-being. Many dimensions of socioeconomic status were absent. And so essentially, these variables on socioeconomic status were just included as controls in quantitative analyses. So there would be a control for income or educational attainment. And of the studies that had significant findings, all but one linked socioeconomic status to overdose in the hypothesized direction, whereby higher levels of disadvantage produced higher risk of fatal or non-fatal overdose. That said, there were significant issues with measurement, with operationalization, with risk of bias, with different analytic approaches. And so we are really not very far along. Even though we talk about poverty and we talked about socioeconomic status, there really isn't a lot of direct research that has that as a primary plane of interest. We've also conducted, and this is nearing submission now, a qualitative narrative review where the literature base is a little bit more robust. And where we were able to systematize the work that we found to identify different mechanisms and pathways through which socioeconomic marginalization is directly linked to drug poisoning and overdose risk. A lot of those categories of mechanism are going to be familiar: material, behavioral, psychological, social, environmental. What we found that I think adds to our current knowledge base is the degree to which so much vulnerability around overdose is related to the interplay between these different mechanisms and pathways, and the ways in which institutions actually reinforce socioeconomic marginalization for people who are already at heightened risk of drug poisoning or overdose. And so, I'm not going to go through all of the mechanisms and pathways that we identified, but what I can say is within this literature, there are lots of calls for changes to drug policy and particularly to social policy to try and affect those socioeconomic conditions that are producing harm. And I can also say that the intervention work that has been done in this area is basically non-existent. I don't think there was a single intervention study that we were able to identify. And so what I'm hoping to talk to you about the rest of today is a case study, or it's an experimental study that we did that really tries to take that observational research and develop an intervention study that robustly evaluates its outcomes. This work really stemmed from an understanding that, work on social policy reform and health inequality is not that robust. It's hard to do, and there isn't very much of it. And part of that is because there has to be a policy change to study, and you end up in a catch-22 where you call for policy change that doesn't get implemented because there's no evidence base to support the policy change, and then there's no evidence base because there's no policy change to evaluate. And so you end up in a cycle where you're reliant on comparative studies and natural experiments where the evidence base isn't as strong. The other reason why it's difficult and why there's not more is even if there's a natural experiment, you actually have to have data on the outcome that you care about. So you can't document changes without the right measurement, and that measurement has to be happening before the policy changes so that you can see what changes after the change is implemented. So again, there's often a data problem. In addition, there's a need for dynamic models where you might be able to understand what happens in a quantitative sort of population health sense, but you might not understand how or why. And that how or why is often where appropriate policy tweaks might come from, or incremental reforms, or understanding ways in which future research could be conducted. That is that sort of scientific refinement of our understanding of what to do in a particular situation. And so this case study that I'm going to talk to you about is related to the income assistance system. And what you're looking at right now is a graph that shows average deaths per day on income assistance payment weeks and not on income assistance payment weeks in British Columbia for the last 4 years. And that light shaded area is the average death per day during a week where there is no income assistance payment out to the province. In British Columbia, our payments are once monthly, usually on the last Wednesday of the month. That dark blue overhang is the additional average death per day during income assistance payment weeks. And so what we see is actually a very sizable jump in overdose mortality on the weeks where income assistance payments go out. And there's a wide-ranging set of, well, wide-ranging, I'm exaggerating a bit here. There are some studies of research that's been done on non-fatal and fatal drug poisoning during those income assistance weeks. And that research comes predominantly from Vancouver and British Columbia, but it also comes from Los Angeles and Rhode Island and Montreal. And what we see is that there are significant increases in non-fatal and fatal drug poisoning around payments, that longer intervals between payments have higher rates of morbidity and mortality, and that when we have community level data as opposed to administrative level data, the prevalence is pretty high. So in addition to the research that's been done on non-fatal and fatal drug poisoning, there's a host of other drug-related harm that increases around payments and is exacerbated around those payments. And I'm not going to talk a lot about all of the research that exists, but what I will say is that fatal and non-fatal drug poisoning is a pretty low bar when we're trying to think about drug-related harm more broadly. The crisis has gotten so bad that we think that that is the only thing we need to be paying attention to in many circumstances, in many research contexts. And I would argue that there are a whole range of drug-related harms that we should be paying attention to. In addition, one of the things that I've seen in my ethnographic work that I've done in the community is that there are all kinds of adaptations and impacts around this synchronized monthly income assistance payment. It has to do with emergency and police having to overstaff in inner city neighborhoods, which means surrounding areas are underserved. We have overdose prevention sites that extend their hours to make sure that people can access supervised consumption supports around the clock. And that poster in the middle is a cannabis dispensary that stays open all night on the day that income assistance payments go out, because that direct deposit lands in people's bank accounts at midnight. And so they have adapted their hours so that people can go and buy cannabis as soon as they have money. And in all of the scientific research and the other work and observations that have come out around income assistance payments, there's sort of two effects that I have focused on and that I've identified. The first is an individual effect where and these effects are those signals that create incentives for increased use. The first is an individual one that we all have whenever we get paid. There's a signal that results in increased consumption. It might mean that you go shopping for groceries, or you go buy those shoes that you were looking for, or you go out for a drink after work to celebrate being paid because it's payday. But there's also a social effect when whatever is being consumed has social underlying cues. And we know that substance use has those cues. So you can think about this as intending to go out for a drink after work to celebrate payday, but drinking 4 instead of 1. And so the question that I'm really asking with this work is whether or not it's possible to disrupt these signals for increased use. So if we were to stagger and desynchronize payments, could we disrupt that social effect? And if we were to split payments, could we disrupt that individual effect or make it a little bit lesser in magnitude? And so essentially what I'm asking is, if this were the income assistance schedule in British Columbia in 2021, What if it looked like this, or even like this? What if it wasn't just a single day that creates a sociocultural event that taxes some service providers that results in other service providers having no one needing their services, and we were to distribute those payments and those cues for use across the month? And so this is what we did. We tried to design an intervention that would disrupt those individual and social signals. And we used the current system as a control. And then what we did was we designed two interventions. One in which people would receive a payment once per month and not during payment week. And once where people would receive a payment twice per month, but again, not during payment week. And the way that we did that, income assistance payments in BC have two parts. One is a shelter allowance, and that can be paid directly to a landlord. And one is a support allowance. And we had the shelter allowance directly paid to landlords and the support allowance directly deposited into our community partners who were a credit union. And then that credit union made those funds available to people in the study, depending on the schedule that they were assigned to or that they were randomized to in the experiment. And so these were our hypotheses. I'm not going to read them directly, but really we were thinking about desynchronizing payments as trying to reduce that social signal, as increasing payment frequency as trying to reduce that individual signal. We were also interested in overall drug use and drug-related harm, and I'll speak briefly to a couple of outcomes related to that. We also engaged in widespread measurement of essentially any kind of other disruption that we thought this intervention might impact. We really wanted to pay attention to the potential that there would be unintended consequences to this kind of policy pilot. And so we measured a lot of those secondary outcomes, and we also teamed up with a bunch of community partners and stakeholders that ranged from drug user advocacy organizations to ministries, to the police, to care providers, and of course to the bank that we worked with to try to implement this intervention. This is what the formal study design looked like. It was a randomized controlled trial, and we had the control arm and two intervention arms, combined with a survey-based assessment as well as a qualitative narrative assessment to really both identify what happened and the why and the how of what happened. I think it's important to mention that after we'd been collecting data for about 8 or 9 months, we adjusted our recruitment targets and our allocation ratios to try and oversample into the experimental treatment arms. We had some challenges with intervention withdrawal. And we made a couple of other changes to further promote participant safety and look at feasibility as an outcome. Our primary outcome was a 40% increase in either the frequency, quantity, or number of drugs used, coinciding with government payment days. And so essentially we were curious primarily with what happened to people's substance use patterns on the days when everyone else was paid. But it was also really important for us to look at what happened on individual payment days, which for people in the intervention were different. They didn't happen on that same government payment day. They were happening at random days throughout the rest of the month. And so we also looked at that same outcome on individual payment days. In terms of measurement, we used the timeline follow-back instrument. For people who aren't familiar with it, it's a calendar-based instrument that allows you to collect daily substance use information. And so people were in the study for 6 income assistance cycles, so 6 months. We talked to them every 2 weeks. And so we were able to obtain daily substance use information for about 200 people for 6 months. So we were able to get really rich data to analyze in the interest of answering our scientific questions. We also measured, as I mentioned, a bunch of secondary outcomes. The ones I'm going to talk about today are exposure to violence and non-fatal drug poisoning. Those are the 2 primary ones that I'd like to tell you about today. But there are a number of other secondary outcomes and analyses that are in process that I'll be keeping my eye on in the next little while. I'm not going to go too much into our analytics strategy, but essentially, we did what you do when you're analyzing experimental data. We made sure that we looked at pre-treatment equivalence, so making sure that our study arms were comparable. And there's a lot of words there, but essentially, we tried to cut the data every way that we could think of to really make sure that if we had a finding, it was a robust finding. A key thing to think about in all of the different ways that we cut the data is that we looked at our data both in terms of an intention to treat analysis, where we analyzed everyone's observations according to how they were randomized in the study, whether or not they were still on the study intervention, as well as what we identified as a modified per protocol specification, whereby essentially we categorized people's observations according to whether or not they were under the intervention actively at a given point in time. And so the primary outcome paper has now been published. It came out last year, and this came out in the Lancet Public Health. We were thrilled that it landed in the Lancet Public Health. This paper really focused on our primary outcomes of government and individual payment days, as well as exposure to violence or violence victimization. Briefly, we had 45 people in the control arm, 72 in the staggered, and 77 in the split and staggered. And in terms of our demographic breakdown, we had just over half of our participants. We had 194 participants in total. Just over half were women, and just under half were either Indigenous or non-Indigenous people of color. And so we had really good demographic representation. In terms of people's participation patterns, we were able to complete 80% of our scheduled follow-up visits, which we were very pleased about with a really intense interview schedule. We weren't sure that that was going to go as well. We only had 26 people complete the full intervention protocol. 89 completed a portion of the intervention protocol, but only 26 completed the full intervention protocol. That becomes scientifically important later on. We lost 25 people to follow up, so about 13% of the initially recruited sample, and we lost 6 people who died during or shortly after the study for reasons that were unrelated to their participation, but tragic losses in many cases nonetheless. This is what our formal participation diagram looks like. I'm not going to go into this in a lot of detail, except to say that it became really scientifically important or scientifically interesting and relevant when we looked at what drove people's participation patterns, why they stayed on the intervention, why they left the intervention. I'm also not going to belabor the sample characteristics too much, except to say that when we looked at pretreatment equivalents, we had an unequal distribution of folks who were transgender and folks who were non-Indigenous people of color across the study arms. And so we collapsed a couple of those categories to make sure that our demographic categories were analytically viable. We also had a relatively high intensity using population. So a significant proportion of the population were using on a daily or more frequent basis. Quite a few people who were enrolled in some form of substance use treatment, and a very high prevalence of non-fatal drug poisoning in the 6 months prior to baseline. And these are our results. And it's a lot of work for a very simple diagram. But what I would say for those who need the reminder, if that dot is above 1, that means there's a positive relationship between being in the intervention and increasing your drug use. And if it's below 1, it means there's an inverse relationship. So if you're in the intervention, you're less likely to use, to increase your substance use around individual and government payment days. And so what we found was that participants in both intervention arms were about 1/3 as likely as control arm participants to increase their substance use around government payment days. And in terms of their individual payment days, so those are the days when the community isn't being paid, but the people in the study are being paid, people in both intervention arms were about half as likely as the control arm to increase their substance use. And so it wasn't just a question of displacing the increased substance use to the days when people got paid. We saw an overall decrease both on government payment days and on individual payment days. Our narrative synthesis was really able to map the mechanisms of action, and I'm not going to go into this in a lot of detail, but What I will share is that for those who maintain desynchronized receipt of their income assistance, what we saw was that social incentive to use decreased, and that the receipt of income was then separated from the social experience of substance use. So this is what one person had to say about it. She said, by the time I get mine, there's a spent. So it's not so much pressure. People coming over saying, let's get this, let's get that. Before, when I got my check on government check day, I would spend at least $100 on drugs. And instead of doing that, I usually just spend 25 for a couple of days. When I get my money, everyone else is broke. So I go pay my bills and go shopping. I used to owe almost 200 in drug debt by the time I got my check, and that stopped too. And so we're seeing multiple adaptations as a result of this intervention that are supporting the financial well-being of this particular participant. And I wish that it were a straightforward good news story, but unfortunately it's not. When we look at our outcomes related to exposure to violence, while our statistical power is lower, and so the statistical signal is a lot weaker, what we saw was that overall exposure to violence increased instead of decreased among some intervention participants. I think it's important to note that there were very few reports of exposure to violence that coincided with people's desynchronized payments. So it wasn't that they were getting paid and then immediately being targeted. But there was a disruption that increased people's vulnerability to violence. And it was really important for us, rather than report a single outcome in our first paper showing the empirical results, that we showed the complexity of the results that we were seeing in preliminary analyses. We can talk about potential explanations for that around, how people who owe drug debt, they are often expected to repay that drug debt on income assistance payment days. We can talk about potential targeting because of resource differentials. We don't 100% know, but it was really important for us that we look at a range of our secondary outcomes alongside our primary outcomes to make sure that we were not creating unanticipated consequences. I also want to talk a little bit about our non-fatal drug poisoning analyses. And everything that I've shown you up until now was published in the Lancet Public Health article. But what I'm going to show you now are preliminary analyses that are about to be under review. And so keep in mind, these haven't been peer reviewed yet, but I think they're really germane to our ongoing discussion of drug poisoning and social policy, and really thinking about the various ways in which interventions are possible and potentially effective. So we measured drug poisoning by looking at people's symptoms. We asked them if they had any unwanted negative reactions from using too much of any kind of drug. And we listed a whole host of potential overdose responses. And our focus was on symptoms because of that range of potential responses, and the fact that just asking someone whether or not they've overdosed means very different things to very different people. And so we were trying to bring a bit of precision in our measurement of overdose and non-fatal overdose. Serious poisoning, which included losing consciousness, having blue lips or slowed breathing, a seizure or psychosis, was our main key outcome of interest here, but it wasn't the only concern. And we looked at both any poisoning and serious poisoning through a number of different operationalizations. Primarily overall likelihood and frequency. The government payment day and individual payment day data wasn't super well powered, and due to an anomaly in the data, we weren't able to look at that for serious poisoning. Here's what we found descriptively. Almost 9% of every observation that we took in had a report of a non-fatal drug poisoning. I thought that was astonishingly high. 81 of those observations involved serious drug poisoning, so almost 4.2 of our total observations. And those 81 serious drug poisonings occurred among 48 unique participants, so over 25% of our sample. And of the 6 people who passed away during the study, 3 of those were to fatal drug poisoning, and they were unrelated to study participation, but I think it's worth noting here. When we looked at any poisoning as an outcome, there were no significant results for any of the analyses that we looked at. And we, again, cut the data every way that we could think of to cut the data. And so that was encouraging. The intervention was decreasing substance use, but not increasing any poisoning, any poisoning outcome. That was not the case when we looked at serious poisoning. In some analyses, not all analyses, participants in the split and staggered arm were more likely to report a serious drug poisoning. And again, when we looked at the frequency, participants in both intervention arms reported a higher risk of more frequent serious poisoning. In some analyses, not in all analyses. And to give you a sense of trying to sort through how to interpret these results, this is a table where each one of those cells is an analysis that we conducted, and all of the different specifications for each of the outcomes are listed on the left. Intent to treat, modified per protocol, different outcomes, et cetera, et cetera. So a lot of different outcomes that we were looking at, or a lot of different analyses that we're trying to distill. And those blue shaded cells indicate statistical significance in the direction that we didn't want, indicating that people on the intervention were more likely to have a negative overdose outcome. And so this is really something that gave us pause. And I should mention that the study never reached completion because in our first set of preliminary analyses, we already had signal of effectiveness for our primary outcomes, and these safety concerns around overdose were starting to emerge in preliminary analyses. And so the study was stopped. We also asked individuals about whether or not they received medical help. And I'm also very sad to report that in most cases, in almost 4/5 of cases, people didn't receive any medical help for the negative experiences that they experienced. There are a few additional considerations that I want to mention around these particular findings, and those are other variables that really cropped up as being significantly associated with risk of overdose consistently. And the most consistent variable that was associated with non-fatal poisoning in all analyses was having a lower level of income assistance. Income assistance in British Columbia is tiered depending on whether or not you received disability supports or not. And so the lower your income assistance, the more likely you were to overdose. High intensity and higher risk drug use were also associated with non-fatal poisoning in sort of consistent ways. There was some sociodemographic patterning. And I would add that, our statistical signal is relatively weak. Our confidence intervals are very wide. These aren't terribly precise estimates, but the statistical signal is there and we need to pay attention to that. I'm going to spend, what this tells us really is that the intervention worked exceptionally well for some people and it did not work at all for others. And so here's an example of a woman who really benefited from having a desynchronized schedule, but really couldn't handle having her payments split. She said, I was just running out of everything and a 5-weeker coming up again. There's no way I was going to make it on those 2 checks. I buy all my food for the whole month at the beginning of the month, so I don't have to worry about food. There was just not enough money there. I couldn't buy in bulk, and it's more expensive to buy little like that. I took a few days to think about it, but it just wasn't going to stretch. I needed all my money so I could stretch my food. And so she withdrew from the intervention because she was randomized to an intervention that really didn't fit her financial management practices. And that came up again and again. When we started to talk to people about their scheduling preferences, one of the things that we saw was that people really recognize that they have different needs. And so we had almost 3/4 of the sample say that they would favor a system where they could actually choose what their schedule looked like so they could make it match their financial management practices. And there were a few reasons why that was the case, but these are really important things to think about when we're starting to get to a situation where our systems have developed enough that they might be able to bring in a bit more versatility. And I'll speak a bit more about that in a second. Empirically, we had really mixed results. Strong signal that the intervention had beneficial impacts on substance use, but then unexpectedly increased some forms of drug-related harm. And so we really need to be thinking about weighing relative benefits and harms and potentially developing better supports that might mitigate those unanticipated harms that we were seeing. There was also a challenge of structural differentiation where we had a very small group of people in a broader system. And so they really stood out, and standing out had potential consequences. A question that the community was asking us when we talked to them about the results was what would happen if there were a broader based intervention. And one of the things that has really been hammered home to me by this work is the potential to explore the idea of individualized social care in the same way that we're all starting to look at personalized medical care. What if it was possible to design our social care systems so that they were better suited? We could improve that match between financial management practice and income assistance receipt. I'm not going to speak about this very long at all, but just want to acknowledge that alongside our scientific work, there was a broad-based community engagement process. And that engagement process really helped us identify the kinds of values that they wanted enshrined in the support system, kinds of challenges people envisioned, and really trying to think through the ways in which social policy can be leveraged to support well-being. One of the things that came out of that consultation in particular was advocating for consistent and equal access to income assistance, regardless of people's drug use patterns, that budgeting might be easier or more difficult. And so developing a system of care that was a bit more client-centered and individualized would be beneficial, and that people had concerns about transitioning to a different system. It would be a big change. We made a series of recommendations to government that really reflected both our empirical findings and the community consultation. And one of the things that again came up in those recommendations was that potential for individualized social care, the need to work with people with lived and living experience who know absolutely better than anyone how they're going to be affected by a particular change. And really hoping to enshrine principles that would promote a bit more autonomy and dignity in receiving income assistance. Before I finish, I'll finish in just a couple of seconds here. I really want to revisit this question of social policy reform and health inequality research, particularly for people who use drugs, in that we've learned an enormous amount from doing this study about what's possible and what's feasible, and about, us having the ability to actually look upstream and develop policy pilots that we can run and test and evaluate, and how important it is to do that, because while changing the payment schedule seems really intuitive, and there are a number of political folks who essentially were like, well, great, let's do it. It's important to understand that the change that is brought by a particular policy reform isn't necessarily straightforward. And so, this was a local study. The questions we were asking was whether or not it was generalizable, and whether or not it would be relevant to other contexts. The kinds of selection effects inherent in experimental research, what works for whom and when. Would this be appropriate for a province-wide change? I don't think that that's the case. And so we were starting to explore, if there isn't a public option, what if banks or credit unions were to team up and try and create ways in which something like this could be implemented for the people for whom it works. One of the things that I also am really pleased about with this study is the data that we were able to obtain and that we were able to process, and that we measured enough outcomes that we were able to capture those unintended impacts. And that the qualitative work really identifies how heterogeneously people respond to a policy change. So understanding those potential harms and how they're produced might allow us to tweak future interventions so that we might mitigate those harms. I'm going to end there. I really do want to acknowledge our study participants, our partners and supporters, the research and administrative staff that helped make this study possible, my and the study's support, the co-investigators and co-authors of this work, and of course, the individuals that we lost over the course of the study. There are 8 sets of initials there because we had 2 people who were not participants in the study, but who were consultants to the study that we also lost over the course of this research. I'm going to end there. I very much look forward to people's comments and to their questions, and I thank you again for the opportunity to share this work.
Thank you very much, Dr. Richardson. That was a fascinating talk. Thinking about it just from the perspective of the United States, you've really grabbed the third rail and put it in your teeth in terms of, a hot topic issue. Just so people will recall, We went through in the 90s the welfare reform, which a lot of its focus was on preventing people with substance use disorders from getting income supports using the disability, changing the disability law. So it's interesting to see how things have matured there. So let me just start and then we'll open up for questions. And so I think I just had one question related to the qualitative part. And it's an area I think that is not well studied by me or other people, which has to do with the relationship of actual cash to actually getting drugs, which is that most people will use a lot more drugs than they could possibly pay for. And that's because the way they pay for drugs isn't through directly buying them most of the time. And so were you able to look at that pattern and see if that changed at all with the staggering? I mean, you have a signal of it, right? Yeah. Because when people were saying like, I'm not using much, because the sort of the market of when they're not synchronized, yeah. The market of people buying drugs sort of, evaporates a bit. And so I just wonder if you had any findings related to that sort of secondary, but probably primary way that people acquire drugs.
Yeah, I mean, I think one of the things that was really interesting for us, and that is interesting in the observational research that was done not by us a long time ago, that really identified there's a lot of work among veterans and veteran supports in this area. And one of the really surprising findings out of that work that Mark Rosen captured in a review a long time ago was that the income assistance schedule changed the pattern of substance use, but not the overall quantity over the month. And so there was this money signaling that would intensify use at a particular time of the month, but in the absence of that money signaling, people used about the same amount, but they just distributed it across the month. And one of the things that we found, there's a couple of papers under review right now around drug debt management for people in the study. One of the things that we found is that people really, they were happy to not be subject to the social forces that were happening around income assistance. They were really like, it gets me every month. I don't want to do it, but everyone else is doing it, so I get caught up in that. And so a lot of people were really happy to be sort of separated out from that group. And in terms of, the quantities that people were buying, I feel like we probably need to do a bit more work on that, but it would involve restricting the amount of money people have access to, or, increasing the amount of money people have access to really look at whether or not the actual the sort of translation from cash to drugs is something that we don't fully understand yet, I don't think. So I don't know if I'm totally answering your question, but there is a whole strategy around drug debt management and trust signaling and the ways in which people try to make sure that their drug debt doesn't get the better of them that I think warrants looking at, because I think that was also one of the primary drivers of people's exposure to violence, right? And so, yeah.
Well, I mean, I think that I'm can mostly just reflect on what I see in Los Angeles, which is that I know people use way more drugs than they're getting money for.
Right.
So that there's it's interesting when you said people, it actually affected their eating patterns more in some ways than their drug use pattern. But that makes sense to me, because I think you can't exchange drugs for food.
No.
And anyway, so I think there's probably a lot more we need to learn about how people acquire drugs. Yeah. Sort of in these contexts. So that's very interesting.
I know there was a lot of in the qualitative work that we've done, there's a lot of evidence of bartering and pooling and different sort of practices to really maximize your drug value, essentially.
Right. And then of course people coming in buying, right, is a big part of how people end up supporting their use. All right, so do we have, I'm looking at the chat, it doesn't look like we have, oh, here was a question. Okay, so what is your opinion on the safe place to do drugs in our communities? So what do you want to just ask that question? So it's from Rosabelle. I'm sure I'm saying that name wrong. Kane, do you want to just unmute and talk? Yes, please go ahead.
Thank you. Great presentation. Very interesting. And what I was trying to say is that, do you know how they have those places where they can go and get needles and get all the stuff they need, and where it's okay for them to do drugs? My question is, do you think it's like really a good option?
Mm.
Oh,
Yeah,
I'm just so
if I'm
conflicted.
understanding your question correctly, you're asking about supervised consumption facilities, like a safe
Yes.
injection site, those kinds of things.
Yes, thank you. I don't remember that. Yes.
So, I mean, in Vancouver, we've now had a government supported supervised consumption site it'll be 20 years in 2023.
Oh, wow.
And we have many what we call overdose prevention sites, which are not necessarily government sanctioned, but the government is allowing for them because they allow for the supervised consumption of otherwise illicit drugs. And there is it's an entire other presentation, but there is a really robust evidence base that supports the positive impacts that supervised consumption has on people's substance use patterns, their overdose patterns, their infectious disease risk, their enrollment in treatment, et cetera, et cetera, et cetera. And so there's a really robust evidence base that supports them and the positive impacts that they can have. And often there's a problem of people not wanting them around. There's a NIMBY problem of people not wanting them in their communities and in their neighborhoods. But our experience is really that they tend to improve more than they negatively impact communities. There are many studies that support that, and so I personally support them, and I think that support is a really evidence-based.
Thank you. Thank you very much.
And then Michael Cousineau, your hand's up. Feel free to ask your question.
Hi, Lindsay. Can you hear me okay? I have a question about how you have communicated the results of your study to policymakers, government officials, and are you worried at all about misinterpretation, particularly when you have, these nuanced negative findings that affect some people, not affect others? It's very easy to misinterpret some data. And what's your experience in doing that?
Thank you for that question, Michael. One of the things I didn't talk about was that over the course of this study, I had an entire full-time person dedicated to knowledge translation. And we worked together to communicate that we were doing the study with government, to give them updates on progress. We provided them with confidential technical reports that provided full transparent data analyses and our interpretation. And I've undertaken multiple briefings with policy officials and politicians and ministers and those kinds of folks. And so it's really been an intensive and concerted effort. And one of the things that I am happy to say is that initially they were not supportive of the study at all, but that changed over time when they learned that I was going to be fully transparent with the findings. And they have had the capacity to understand the nuance and understand that it isn't simple, in part because over time we've developed a relationship whereby they've given me enough time to spend with them to explain the nuance. And so in the week that our preliminary results were first available, I went to the provincial government and spent an entire afternoon talking to them and answering questions and talking about feasibility of system reform and those kinds of things. And it really relied on this long-term, intensive, regular relationship that I had built with them. And so there was a really intensive communication strategy. And I do think that while initially they were less willing to have conversations about that nuance, that changed over time, and that the provincial government really should be lauded for being willing to entertain the potential possibility of what we're talking about. So I hope that answers your question.
So I think we have time for just one last question. I'm going to try and combine two of them. So one from Lindsey Young, another from Nina Christie, about the social pressures within groups around drug use. And I guess the question is there a social network intervention maybe waiting to be developed related to payment schedules?
I would suggest that there is. I mean, I think that one of the things that was difficult for our participants was that often their social relationships were disrupted. And so, you know, it's all fun and good to say, I don't want to use on check day. And it's another thing entirely to have something that had been a sort of point of social connection be taken away from you. And there were a lot of people in the intervention who withdrew because of social pressures towards use around government payment days. And so I really do think that developing peer supports to reduce the sort of social disruption that happened because of the intervention could be beneficial for sure.
All right, well, with that, we'll let people get back to their lives. Thanks so much for a really fascinating presentation and for introducing to us in the United States a whole set of other research questions that are not carefully looked at for the most part. Adam, do you want to close out?
Sure. Thank you. That was an awesome talk, Dr. Richardson. And thanks, Ricky, for moderating this. Well, before we go, I just wanted to invite everybody to return for our next set of speakers: Andy Subica, Regina LaBelle, Rahul Gupta, Morgan Philbin, and Michael Stein. As you can see, an all-star cast of policymakers and scientists that are on the slate. So stay tuned. And with that, I'll wish you all a good afternoon.